of the investigators of the VICTORION-Mono program, which is a phase 3 randomized trial, I'm pleased to talk about the data of inclisiran as monotherapy compared with placebo and ezetimibe monotherapy in patients that are low to borderline risk for atherosclerotic cardiovascular disease. These are my disclosures. Inclisiran is a first-in-class novel small interfering RNA that lowers PCSK9 protein, and it's incredibly novel in that the dosing is every 6 months, which really helps us with the clinical issue of compliance that we face every day with adherence to lipid-lowering therapy. In addition, we've had multiple clinical trials, including Orion 10 and 11, that have established the potent LDL-C lowering of inclisiran, but this is on background lipid-lowering therapy, mainly statins. What is not known is how inclisiran performs as monotherapy when there's no background statins. And there is some clinical concern because statins do upregulate the PCSK9 protein, and there's concern that without that statin background therapy and upregulation of PCSK9 protein, that there may be less efficacy of inclisiran. So the VICTORION-Mono trial was conducted to evaluate the efficacy of inclisiran compared to placebo, as well as with ezetimibe monotherapy. So this was a low-risk population of patients who did not have established atherosclerotic cardiovascular disease, and they had a low ASCVD risk score as assessed by the pooled cohort equation of less than 7.5%. They had to have an LDL greater than 100, but less than 190 to be enrolled, as well as a triglyceride level less than 400, and they were not on any background lipid-lowering therapy. And inclisiran was administered at visit 1, and also at day 90, which is visit 3, and the primary endpoint was assessed at day 150. And the primary endpoint was the percent change in LDL-C from baseline to day 150, and the key secondary endpoints were the absolute change in LDL-C as well as changes in PCSK9, lipoprotein A, non-HDL, and ApoB. And so there were 630 patients that were screened, and 350 ended up being randomized, and this was a 2-to-1 randomization with 174 patients in the inclisiran arm. The study overall had a very high rate of completion, with 94% of patients in the inclisiran arm completing the study. These are the baseline characteristics of this population, and what's novel is most of the participants in this study were women, which is very different from most lipid-lowering studies, and we had 63% women, and it was also a very racially diverse population with 40% Hispanic and 10% Black. The mean LDL-C in this population was 135, and this is higher than, for instance, Orion 10 and 11, where the mean LDL-C was about 100. In addition, the BMI in this group was high at 29. So by all conventional metrics, we classify these patients as low risk. But if you look deeper, you see that these patients have an elevated BMI, and they also have an elevated A1C of about 5.5. So even though this is traditionally classified as a high-risk population, we do have to look deeper, and these patients do have features of the metabolic syndrome, which is not surprising because 1/3 of the population globally has metabolic syndrome. In terms of the primary endpoint, what you see is about a 48% reduction in LDL-C, and this is very similar to what's been seen in the other phase 3 clinical trials with inclisiran. And when you look at the different subgroups, you don't see any differences based on gender, race, ethnicity, PCSK9 levels, lipoprotein A levels. So very consistent LDL-C lowering among the different subgroups. And then when you look at the absolute change in LDL-C, it's about 65 milligrams per deciliter, which is about 2 millimoles per liter. So significant LDL-C lowering, again, in the absence of any background lipid-lowering therapy. In addition, you see a significant change in PCSK9, which is expected with inclisiran, and you don't see that with ezetimibe or placebo. In terms of other atherogenic biomarkers such as non-HDL-C and ApoB, you do see potent reductions in both of these biomarkers, as has been seen in prior randomized clinical trials with inclisiran. An interesting component of the study is what happens to lipoprotein A when there's no background statin therapy. And so we see a similar reduction in lipoprotein A levels of about 25%, which is what's seen in other studies. So it's reassuring to see that there is also a significant lowering of lipoprotein A without background statin therapy. And when you look at the waterfall plots, what you see is that inclisiran demonstrates less individual variability, and these waterfall plots are also very similar to what's been seen in the other randomized clinical trials. In terms of safety, inclisiran is extremely well tolerated, as we've seen in the other trials. We did see 4 patients that had new onset diabetes, but however, these were all patients that had pre-diabetes, and as I mentioned in the baseline characteristics, the population in general had features of metabolic syndrome with an elevated BMI, an elevated average A1C of 5.5, and so these patients had pre-existing hyperglycemia before any dose of inclisiran was administered. In terms of the strengths of the study, this is the first study to evaluate inclisiran monotherapy without any background lipid-lowering agents. There have been other studies done with evolocumab, the Mendel study, and there's also an Odyssey mono study that looked at alirocumab monotherapy. Both of these studies were short duration, about 24 weeks, so this is a much longer period of follow-up, and those studies also showed, in the absence of statins and other lipid-lowering therapy, that the PCSK9 monoclonal antibodies had similar efficacy in terms of LDL lowering. As I mentioned before in the baseline characteristics, this was also a very novel study in that there was a significant number of women enrolled as well as a very diverse population. The study limitations are, it was a short duration of follow-up. The primary endpoint was assessed after 2 doses of inclisiran, and there was no evaluation of cardiovascular outcomes. There are 2 ongoing clinical trials looking at cardiovascular outcomes. One is the VICTORION-2 PREVENT study that's looking at the impact of inclisiran in patients with established atherosclerotic cardiovascular disease, and the very novel VICTORION-1 PREVENT study, which is looking at patients that are high risk for atherosclerotic cardiovascular disease, but yet have not had an event, and it's looking at the efficacy of inclisiran in preventing that first event. There was no direct comparison with statins, bempedoic acid, or the other monoclonal antibodies. There was a lower than expected reduction in LDL with ezetimibe, and this could be due to various factors, including compliance. Even in a clinical trial, compliance is not perfect, and so this speaks to how important adherence is in real-world clinical practice and why having an agent that's every 6 months is very beneficial. And also there could be variable expression of the protein NPC1L1 that's on the intestine, which is responsible for the action or where ezetimibe acts. So those are other factors that could be responsible for the lower than expected LDL-C response with ezetimibe. So in conclusion, inclisiran monotherapy was superior to both ezetimibe and placebo in reducing LDL cholesterol, and this was the first study evaluating inclisiran monotherapy. There was really no new safety signals. Inclisiran is overall well tolerated. So what does this mean in terms of clinical practice? I think that many of us are forced to use inclisiran monotherapy because our patients cannot tolerate statins and other lipid-lowering agents. And so when we do use inclisiran monotherapy, we can be reassured that the LDL lowering is very similar to what's been seen in the clinical trials where there is background statin therapy. And also the lipoprotein A lowering is very similar with monotherapy as well as with background statin therapy. So for a full manuscript, you can look at it at JAC. It's simultaneously published today along with this presentation. I look forward to your questions.
Thank you very much. The paper is open for questions. If you have a comment, while Laura is asking, you can walk to the microphone.
Can I ask you, do you think that the lower effect you see on LDL with ezetimibe can be partly explained by the large presence of women in your cohort?
I mean, there's so many different factors, but that could possibly be one factor. But I think adherence is also another factor, and also there's just variable expression of the protein in the intestine. And diet can also have a big factor as well.
I was actually wondering about the Lp(a) levels. I think I missed that, the starting values. So were they high, low?
They were about in the mid-30s.
Okay.
And so they were lower Lpa values. But what we see in terms of that 25% reduction is very similar to what's been seen in the other studies.
Any other questions, comments? If not, then thank you very much. And then now this closes our session.